Hello and welcome to the topic Neonatal Resuscitation Program. By the end of this session, you should be able to discuss appropriate preparation and equipment required for adequate resuscitation, understand and demonstrate appropriate steps in newborn resuscitation per the NRP guidelines, understand current recommendations for resuscitating infants with meconium, and finally, understand how to assign ABGA scores and their significance. Let's get started. Approximately 10% of newborns require some assistance to begin breathing at birth. Less than 1% require extensive resuscitative measures. Although the majority of newly born infants do not require intervention to make the transition from intrauterine to extrauterine life, because of the large total number of births, a sizable number will still require some degree of resuscitation. Let's look at what are the components of NRP. The NRP curriculum has three primary components, which include knowledge, where such example you will need to understand the dose of adrenaline administered, skills, for example, understanding and performing back mask ventilation, and finally, behavior, for example, communication and teamwork. So this module will be divided into few sections. We will be looking at requirements for resuscitation algorithms, the resuscitation process itself, and post-resuscitation management. So let's start, beginning with the neonatal resuscitation requirements. So you would require suction equipment, which include the pulp syringe, mechanical suction and tubing, suction catheters, feeding tube, and a 20 ml syringe, as well as a meconium aspirator. For the bag and mask equipment, this is a device for delivering positive pressure ventilation capable of delivering 90 to 100% oxygen. Face masks are used for newborn and premature sizes, with cushioned rim mask preferred, an oxygen source with flow meter flow rate up to 10 liters a minute, and the tubing has to be ready. You will also require intubation equipment, and these are laryngoscope with a straight blade, extra bulbs and batteries for laryngoscope, the endotracheal tubes, stylet, scissors, tape, or securing device for the endotracheal tube. Next would be preparing the medications, and these include adrenaline, isotonic crystalloids, ampules of sodium bicarbonate, naloxone, as well as normal saline flushes. Finally, miscellaneous, such as gloves and appropriate personal protective equipment, a radiant warmer or other heat source, firm padded resuscitation surface, a timer, warmed linens, stethoscope, micropore, cardiac monitor and electrodes, and umbilical vessel catheterization supplies such as scalpel or scissors, antiseptic solution, the umbilical tape and catheters, and a 3-way stopcock if this is required later. Now let's look at the TABC of resuscitation. T, which stands for maintenance of temperature, A, which is establishing an open airway, B, which means initiate breathing, and C, which means maintaining circulation. Let's look at the resuscitation algorithm here. So as soon as the baby is delivered, assess for 5 signs while the cord is being cut. Is it clear of meconium? Is the baby at term gestation? Is the child crying or breathing? Is there good muscle tone? And is the baby pink? If yes, you may then hand the baby to the mother. If the answer is any one of these assessments are no, then the infant should receive one or more of the 4 categories of action in sequence. Initial steps in stabilization, providing warmth, clearing the airway if necessary, drying the child, and stimulating the baby. This is then followed by ventilation, chest compressions, and administration of adrenaline and of volume expansion. Approximately 60 seconds, which is the golden minute, is allotted for completing the initial steps. Re-evaluating and beginning ventilation is required. The decision to progress beyond the initial steps is determined by simultaneous assessment of two vital characteristics, which include the respiratory rate and the respirations and the heart rate. As for positioning, maintain the correct position, as one may place a rolled blanket or a towel under the shoulders, elevating them 1 inch off the mattress in the sniffing position. If the infant has secretions from the mouth, keep the head turned to the side. The purpose of positioning is to make adequate alignment. Next is suctioning. The mouth and the nose should be suctioned. One should not insert the catheter very deep in the mouth or nose for suctioning because it can cause severe bradycardia or apnea. For suctioning, the size of suction catheter should be 12 or 14 French. The suction pressure should be kept around 80 millimeters mercury or 100 centimeters water and not exceeding 100 millimeters mercury. Next would be dry, stimulate and reposition the child. After suctioning, the baby should be dried adequately using pre-warmed linen to prevent heat loss. The wet linen should be removed from the baby. A brief tactile stimulation in the form of flicking the soles or rubbing the back may be provided in case of no establishment of good respiratory efforts. Finally, free flow oxygen. If the baby continues to be depressed, provide free flow oxygen using a face mask held over the face loosely or by cupped hand. The flow of oxygen should be 5 to 6 liters per minute. Next, we move on to ventilation. So let's look at the indications of ventilation. So back valve mask ventilation is indicated if the infant is apneic, gasping, and respiration is spontaneous but heart rate is below 100 beats per minute. Positive pressure ventilation may be attempted in the spontaneously breathing infant who remains cyanotic despite administering 100% free flow oxygen. In non-vigorous babies born through meconium stained liquor, it is carried out only after tracheal suctioning. The infant's neck should be slightly extended to ensure an open airway. Position yourself at the head end or at the side of the baby to have an unobstructed view of the infant's chest and abdomen. The appropriate face mask should cover the mouth and the nose but not the eyes of the infant. Compress bag using your fingers and observe an appropriate rise of the chest. If the chest does not rise, follow the steps outlined. Evaluate the heart rate and take a follow-up action accordingly. Next, let's take a look at chest compressions. Chest compressions are indicated if the heart rate is less than 60 beats per minute, even after 30 seconds of positive pressure ventilation with 100% oxygen. Once the heart rate is 60 beats per minute or more, chest compressions should be discontinued. The techniques that can be used include thumb technique, where 2 thumbs are used to depress the sternum with the hands encircling the torso and the fingers supporting the back. 2-finger technique, where the tips of the middle finger and the index finger of one hand are used to compress the sternum. The other hand is used to support the infant's back, unless the infant is on a very firm surface. The rate of compression. 1/3 of the depth of the chest is recommended, and 3 compressions are performed and a pause for ventilation left in place for the 4th compression. This gives an effective rate of 90 compressions and 30 ventilations per minute. The heart rate should be re-evaluated every 30 seconds while compressions are being performed. If the heart rate is less than 60 after 30 seconds with effective ventilation, then drug therapy may be necessary. Endotracheal intubation. Well, endotracheal intubation is required for suctioning the trachea in the case of meconium stained amniotic fluid in a depressed infant. Other indications are to provide prolonged ventilation, to ventilate an infant in whom positive pressure ventilation has been ineffective, and to ventilate an infant suspected of having a diaphragmatic hernia. The approximate size of the ET tube for different infants are as listed. So, two people are needed, one to intubate and ventilate, and one to assist in managing equipment and confirming proper tube placement by listening to the infant's lungs. The infant should be positioned in the same sniffing position as for positive pressure ventilation. A laryngoscope with a straight blade of size 1 for term babies or 0 for preterm babies should be tested and in good working order. The laryngoscope blade is introduced between the anterior wall of the hypopharynx and the epiglottis. The appropriately sized endotracheal tube is inserted until the tip lies 1 to 2 centimeters beyond the vocal cords. Many tubes have markings to indicate the appropriate placement. Proper depth of insertion can also be estimated by calculating the depth at the tip according to the following formula. Weight in kilograms plus 6 centimeters equivalent to insertion depth at the lip in centimeters. Now, let's take a look at medications. Drugs are rarely used in neonatal resuscitation but may be needed for the most critically depressed newborns and those with significant anomalies. Note that all drug doses are calculated based on the infant's weight. Since the weight is not precisely known, the physician must clinically estimate the baby's size to calculate the doses. Let's look at volume expanders. So, volume expanders are reserved for situations in which blood loss has occurred or the infant is clinically hypovolemic. Isotonic crystallite solution, such as normal saline or Ringer's lactate, is the volume expander of choice. Naloxone should be given if there is continued respiratory depression despite positive pressure ventilation and the mother has been given narcotics within 4 hours of delivery. And sodium bicarbonate has been given to correct metabolic acidosis. Next, let's take a look at the ABGA score. It is a semi-objective measure of assessing the infant's respiratory, circulatory, and neurological status at birth. It is scored at the first minute and the second minute. Any score of 7 to 10 is normal, 4 to 6 is moderately depressed, and 0 to 3 needs immediate resuscitation. So, what is the management after resuscitation? Immediately after resuscitation, examine the baby completely, weigh the baby, and document the findings. If normal, wrap the baby and transfer to the mother, initiate breastfeeding within half an hour, communicate with the mother, and give discharge advice as well as follow up plans. In summary, evaluate the need for neonatal resuscitation and prepare adequately. Then, evaluate the newborn and follow the recommended protocol. The Neonatal Resuscitation Program is a course that conveys an evidence based approach of care of the newborn at birth and facilitates effective team based care at the time of delivery. So, house officers will be undergoing this program in their neonatal intensive care unit rotation in order to be functional in the unit. We have come to the end of this topic. We hope it was insightful and will be able to aid your neonatal resuscitation training during your stint in pediatrics. Thank you.